Good morning, everyone, and happy Friday. Welcome to today's presentation, Medications for the Treatment of Opioid Use Disorder. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and would be uploaded to the CMH YouTube account for future reference. We've had other questions about our presenters being able to share their PowerPoints, and they will be sharing, and so will Dr. Romanek today. So after the presentation, you're going to be able to go onto our website at sccmh.org and be able to get a copy of the PowerPoint as well too. For those of you that are logged on, I want to remind anyone that is requesting social work education credits, social work continuing ed credits, or a certificate of attendance, it is very important that you remain on the webinar till the absolute end until we leave, just so you can get your full credit as well too. Please feel free at any time to use the chat box below to make any comments and certainly ask any questions. Dr. Romanek is very open to questions, so go ahead and enter them at any time. Add your comments. And if time allows at the end, if we have time, Dr. Romanek will go ahead and get to any kind of questions that we have, as long as we have time at the end of the webinar today. So with that, I'm going to go ahead and introduce our presenter today, who is Dr. Janice Romanek. Dr. Janice Romanek has been with us for the past 2 years. This is her third year presenting at our Recovery Summit. She's the medical director of Sacred Heart Rehabilitation Center. She's completed her undergraduate at Oakland University and obtained her medical degree at Michigan State University College of Osteopathic Medicine in East Lansing. She went on to complete her residency at Henry Ford Macomb Hospital in Clinton Township. She's a board certified in both family medicine and addiction medicine by the American Board of Osteopathic Family Physician. Dr. Romanek is an established physician in the field of addiction medicine with over 15 years of experience as an advocate of medication for opioid use disorder programs. She works to educate those through didactic sessions on the benefits of medication for opioid use disorder, which is also MOUD, which you'll hear her refer to, and the stigma surrounding it. And with that, I'm going to go ahead and turn everything over to Dr. Romanek.
Thank you. So yes, I'm the medical director of Sacred Heart Rehabilitation Center, and I'm going to be discussing the medications for opiate use disorder. A couple of years ago, it used to be known as medication-assisted treatment, but now the new terminology is medications for opiate use disorder, because when it was referred to as medication-assisted treatment, we're not really assisting them with medications, we're giving them medications for their chronic disease state. I have no conflicts or interests or disclosures that are relevant to any of the content of this presentation. So what I'd like to kind of look at is the recent trend that we've seen from 1999 up to 2020. Usually the National Survey on Drug Use and Health and the CDC releases their most recent ones every September, so it'll come out this month. But as of the last year, since 2020, since COVID hit, what we have seen is an increase in opioid overdose deaths, and it's by 30% and prior to COVID. So we have seen quite an uptick in overdose deaths, and they're due to opioids. Specifically, we see a lot with the synthetic opioids like fentanyl, tramadol, things like that. And we're seeing pretty much not really so much an increase in heroin use, because there's so much fentanyl that is replacing heroin. So what are the risk factors that contribute to the development of addiction? So there's multiple things that go on when someone becomes addicted to different substances. You have the environment that they've grown up in, you know, a chaotic home and abuse, if the parents are using any type of peer influences. You look at their biology and genetics, you know, are they genetically predisposed to go ahead and become a substance use disorder person? Their gender takes a role, along with some of the mental disorders. The types of drugs that they start with, the way they administer them, the route of administration, and how easily they're available. And then brain mechanisms that lead to addiction. So there's substance use disorders, they're complex and they involve all of these things. I am going to talk a little bit about the brain mechanisms and how it affects the brain, so that you understand how the medications that I'm going to discuss work at the brain level of the brain. So when we look at the neurobiology of addiction, we need to know that all of the brain regions need to be considered when we develop strategies to treat addiction. So for example, the prefrontal cortex is where a lot of the counseling will, if you were giving counseling, that's where it would affect that area. Motivational interviewing is at the orbital frontal cortex. The one that I'm going to focus on specifically is the nucleus accumbens. So that's the medications that I'm going to discuss: naltrexone, buprenorphine, and methadone. And also the ventral tegmental area is also where those three medications act. And then if you were doing therapy and antidepressants, that's also the amygdala. So I'm going to focus on the nucleus accumbens and the ventral tegmental area. So when we look at it, we need to realize that addiction is a chronic relapsing disease. It's not something that when someone is treated, all of a sudden it's gone, they're cured and they don't have to think about it anymore. So what happens when someone's addicted to a substance? You get dopamine release at the nucleus accumbens. And then this leads to that reward, that motivation, the pleasure and euphoria they experience. It affects their motor function. It causes them to have compulsive behaviors towards the substance. And it also affects their memory processing and their conditioned responses. So what we end up seeing is we see the results in structural and functional changes in the brain when people are using drugs chronically. So how does the reward circuit when someone's using work? So the ventral tegmental area, that one area I had showed you, that consists of dopaminergic neurons. So those are what are going to release dopamine, and they respond when stimuli indicative of a reward are present. So when we break it down to the nucleus accumbens and the prefrontal cortex, if you want to think of it as driving a car, we think of the nucleus accumbens as your gas pedal and the prefrontal cortex kind of as your steering wheel. So when the nucleus accumbens is activated, that's going to fuel your gas pedal. It's going to fuel that appetite and behavior. And that's what's going to lead to those conditioned behaviors and the motivation to continue using. And the prefrontal cortex is kind of your steering wheel. That's going to drive the behavior to the appropriate goal that you're aiming for. So the question is, with the prefrontal cortex, if it's going to drive you, that's going to determine if the behavior is going to be elicited and you're going to act on that impulse. So that's kind of the reward circuit when someone's using, for example, heroin or any of the substances. So what does that look like when we look at pictures of the brain? So dopamine receptor binding typically is lower, and stimulant-induced dopamine release is reduced. So what we see, so if you're looking at the photo, you see the comparison subject, which is on the left of the photo or of the scans. You're going to see a lot of red area. So the red area is an increase in dopamine receptor availability. So the more blue it is, the less availability for those receptors that can take on dopamine. And the more red it is, the more that they can accept that dopamine. So if you look at the comparison user versus on the right, the drug abuser, what you're going to see is less red. So there's less dopamine receptor availability. If there's no receptors for the dopamine to bind to, then the drug abuser is going to continue to seek out more substances in order to get that dopamine release. So that's kind of what you see when you look at the two. So the hypodopaminergic function stimulates craving. So because they don't have as much dopamine, that dopamine availability where the dopamine can bind, that redness we see in the comparison subject, they're going to continue to seek out the substance in order to continue to use. So what does that look like in the opioid dependent brain versus the non-opioid dependent brain? So on the left, you see the non-dependent brain, and yet again, you see all that red in the brain area. So versus the right, which is the opioid dependent brain, you don't see a lot of red. So these PET scans show changes in the brain function caused by those opioid dependence. So that lack of red on the right and the opiate dependent brain shows a reduction in those brain functions. So that's going to drive the individual to continue to abuse those substances. So what we found is that extended methadone and buprenorphine maintenance breaks that habit and associations between the triggers and drug self-administration, and it does it so by blocking the reward system. So that's where medication comes into play. So what happens when someone's in a hypodopaminergic state? So they have low levels of dopamine that's associated with this chronic drug use. What we see is altered behaviors and emotions. We see altered cognition and learning. And we see memory or conditioned associations. And we all have this. It's not just drug abusers. It's, for example, one of my favorite examples, how our memory remembers things and condition associations is, for example, it's a stamping in. So it affects the stamping in of that memory, and it attaches motivational importance to otherwise neutral stimuli. And that's going to drive the individual to seek out more despite the negative consequences. So one example that I like to use is for if you used to go to grandma's house and grandma used to bake cookies prior to your arrival every time you arrive. So every time you walk into grandma's house, you smell cookies. And then you knew you were happy, you felt like you were at grandma's house, you smelled those cookies. Now it's 10 years later, 15 years later, and you walk into a house that smells like cookies, and you all of a sudden remember your grandma, and you don't know why you do it. But all of a sudden it brings back those memories and that conditioned association. That's the same thing with individuals using substances. That's that stamping in of memory, where you have this response to a certain stimuli that seems neutral, right? So smelling cookies doesn't really seem very exciting. It's a neutral stimuli, but that drives you to think about things. So for individuals using, that's going to drive them to seek out their drug of choice despite those negative consequences. You're going to see people with low dopamine levels are going to have cravings. They have impulse control, which is where the prefrontal cortex comes in. One example of this, for individuals not using substances, if someone was in a car accident and they damaged their prefrontal cortex, those are the individuals who have severe impulse control. So those are the individuals who blurt things out. They don't mean without thinking. They say inappropriate things without realizing they're doing it because there's damage to that prefrontal cortex. And we see that in individuals abusing substances also. And we see that they have an increased vulnerability to stress. So what medications are we going to talk about for opioid dependence? The first one we're going to talk about is methadone, which is a full agonist. We're going to talk about buprenorphine, which is a partial agonist, and naltrexone, which is an antagonist. And so I know I don't speak a lot about therapy in this session. I mainly focus on the medications because no one has ever questioned me, why would they go to therapy if they're abusing substances? That's silly. No one ever questions me on that, but I do get a lot of questions on why put them on medication. That's just a crutch. Those are the comments that I've heard. So that's why I focus on the medication. So studies of cognitive behavioral therapy versus medications for opioid use disorder versus the combination of both have shown that the best outcomes for our patients is when we combine both cognitive behavioral therapy and the medications. So the first one I'm going to talk about is methadone. So it's a mu opioid receptor agonist. So it binds to the opioid receptor and it fully activates that receptor. And the goal is to suppress opioid withdrawal symptoms for 24 to 36 hours without causing sedation or intoxication. So when we first initiate someone on methadone, we do warn them about and caution them about oversedation and driving because they are new to the medication for the first week or two. But once someone's on a stable dose of medication specific on methadone, there is no sedation or intoxication. They usually are stable on their medications and they function normally. So the goal also is to block the withdrawal symptoms, the cravings, and those reinforcing effects of the opioids. It is a Schedule II substance, and it does require 3 to 6 months to achieve stability. And that's really important for people to understand. A lot of individuals come in and they want to go on a medication and they say, but I hope to be done in a month. Well, that's not realistic. So when we put someone on methadone, it takes 3 to 6 months to even achieve stability. And when someone does go on methadone, that's not usually our first option. So being that there's 3 medications, there's methadone, buprenorphine, and naltrexone. If someone who was, let's say, a 19-year-old came in and had never been in treatment and asked for methadone, that would not be something we would consider. So you have to also look at their history and why they want to be on it. So what I like to think about is kind of like a pool where you're wading in. It's kind of like one of those slow ones, like a beach type entry. So if someone's never been in treatment before and they're ready to dip their toes in the water, and maybe they step into the water and they're ankle deep, that's where we want to start trying maybe detox, residential, Vivitrol. Those are good options for them. Now, if let's say that didn't work, they would wade into the halfway point where it's at their waist, and that might be where we attempt buprenorphine because other modalities have not worked for them. Now, let's say, that's not working for them and they're continuing to use illicit substances. That's where we're going to stick them in the deep water of the pool, and that's where methadone comes in. So it's deep. They have to tread water, which means they've tried other modalities. They've tried detox multiple times. They've tried residential. They've tried buprenorphine. They've tried Vivitrol. None of those things are working for them. And what I kind of like to say is I'm never going to shove someone into the deep end where they haven't learned to swim until we try other medications with them. So methadone is kind of like one of the medications that we use if other modalities have failed, or have not failed, but have not worked for that individual, because we do like to individualize treatment, and each person's going to be on a different medication. And until you start trying each medication, you're really not sure what's going to work for them. And because each person does well on something, it's just a matter of what they do well on. So yet again, it requires 3 to 6 months to achieve stability. So most people who end up on methadone are on it for quite a period of time, if not lifelong, because other modalities haven't worked. And our goal is to correct any biological abnormalities that may be present in an opiate dependent individual. So when these individuals go on this medication, the goal is to have them function normally in society. So we want them to be able to hold a job, pay their rent. They want to be able to function and go to their child's soccer games without worrying about what other things are happening, or without those cravings and those impulses to use. We want to create a normal functioning individual. So methadone's unique in distribution. So it has to be distributed through a medication through a licensed narcotic treatment program that has to be registered by the state, an outpatient treatment program. It can't just be written out of an office for opiate use disorder. So what happens at the clinic is it requires a physician to manage. It's kind of like a one-stop shop. We have everything there for methadone patients on methadone. It requires a physician to manage the dose. There's nurses to dispense the methadone, and actually methadone in a OTP in a program is liquid. So most methadone on the street, so if someone's taking illicit methadone on the street, most of the time it's a tablet. Tablets are written from pain management perspectives. All OTPs are required to dispense it as a liquid to decrease diversion. We have set hours for administration, and initial attendance to the methadone program is daily. So methadone is really a commitment. It's not something you're just going to want to jump into. So individuals who are on methadone, and when I say it's a commitment, it's a lot of work to be on this medication. It's very highly regulated by the federal and state entities. So individuals have to come in every single day to get their medication. So they will have to get up, come to the clinic, get their medication dose. And when they walk in, we have multiple kind of safeguards. They check in with the front desk. They're assigned a certain number. We have their photo. Then they go see the nursing staff, and the nursing staff can determine how they're doing on their dose. Are they over sedated? Are they intoxicated? Are they safe to dose? They are mandated to dose for a minimum of 90 days in person, and they will not get any carries or take homes until they're testing negative, and that's after 90 days. And then they only start with 1 to 2 take homes at the most. So it really is a commitment to come to the clinic every day. And that's why we have early morning dosing. We open between 5:30 and 6 a.m. So it is a commitment. It's not something easy to be on. We also have counseling, psychosocial services, and medical services located at the clinic. We do periodic urine drug screening. So if someone's new to the clinic, that's done on a weekly basis. And then as they achieve sobriety and they're doing well, we can decrease them to maybe every 2 weeks and then monthly after a while. We do run the MAPS, the Prescription Drug Monitoring Program, through the state of Michigan. I do like to mention that on the MAPS, methadone dispensed out of an OTP or a narcotic treatment program does not show up. So if someone's getting methadone from us, Sacred Heart, or any of the other providers, they will not show up on a MAPS. So if someone was to run that, but why we run MAPS is we want to see what else they're filling. Are they filling any other narcotics like hydrocodone, or are they filling any benzodiazepines that might interact with the methadone and cause oversedation? So every time we see them, we do run a MAPS on them. So how can you write methadone outside of this highly regulated OTP? There's only two reasons that you're allowed to do it. Physicians can prescribe methadone if someone's hospitalized. So if someone does go into the hospital, say their appendix ruptured, the hospital will reach out to us and verify dosing with the OTP with us so that we can go ahead and continue dosing them in the hospital. And then the other reason is pain relief, that a prescription from a pain management doctor. Typically, if a physician who's a pain management physician is writing methadone for pain relief, their average dose is between 30 to 40 milligrams, and those are the tablets. So only 4%, as I said, of methadone is diverted out of an OTP because we are so highly regulated. So the other 96% that's located on the street are coming from pain management doctors in the tablet form. So how do we dose methadone? Typically, the first dose is 30 milligrams, anywhere from 10 to 30 milligrams, but it cannot exceed 30 milligrams on the first day. There is the possibility of going up to 40 milligrams, but how it works is methadone peaks in 3 hours. So if you dose someone at 30 milligrams but think they might need more, you don't have to have them come back in 3 to 4 hours and reassess them to make sure there's no oversedation if you wanted to give them that other 10 milligrams. Classically, people don't come back. So, if you did start them at 30 milligrams, you'll see them the next day and see how they're doing. And you see it more when someone's inpatient and we're monitoring them constantly. So with methadone, you have to start low and go slow. The most common time for someone to overdose on methadone is within the first 2 weeks of treatment. So that's why we are very, very careful with it, especially when someone begins on it. So adjustments typically are in 5 to 10 milligram increments, and we do them every 3 to 7 days. Half-life of methadone is 24 to 36 hours, and the average dose is different for everybody, but the average dose ranges from 80 to 150 milligrams. So if I start someone on 30 milligrams and I know I can't increase their dose for 3 to 7 days, and they're going to probably, maybe be at 80 or 90 milligrams, it's going to take a month or two minimum to get them up to a therapeutic dose that works for them. So individuals who think they're going to come in, be there for a week and be done, that's not plausible. It just doesn't work that way. In pregnancy is a whole different ballgame, but in pregnancy, we consider split dosing due to the rapid metabolism of the pregnant mom. So why do we have to go so slow with methadone compared to other opioids? Considering they're using opioids, you would think they have a tolerance, which they do, but methadone is kind of a different type and a unique medication, and that's why it's so highly regulated. So in order to attain something called a steady state, meaning an equal level in the bloodstream, you dose it slowly. So let's say on day 1, I gave 30 milligrams. You can kind of see, like, on day 1, you come up, you have a peak and it goes down. The next day again, you dose them on 30 milligrams. The peak goes higher and comes down. The next day, day 3, you do the same thing. The peak goes up and comes down. So you actually don't know what 30 milligrams is going to look like till they hit day 3, 4, 5. So if someone was started on 80 milligrams, that would raise that bar of where methadone is, and someone could overdose very easily on it. So that's why the most common time for an individual to overdose is if they're given too much methadone within the first 2 weeks. And that's also why we wait anywhere from 3 to 7 days before we consider a dose increase, because if on day 0 they're doing fine after the first dose, if you had them on 80, maybe by day 4 they're going to overdose because that's just too much and it raises the level. So you do have to go ahead and go low and go slow with it. So what are the pros to methadone? You have a structured recovery environment. It's kind of like a one-stop shop. Medication, therapy, peer recovery coach, it's all at the same place. You have more frequent monitoring because they do come in every single day and you can assess them every single day. If they come in and they're in crisis, there's people there to talk to them, whether it's a peer recovery coach, therapist, nursing staff, everyone's on site to kind of work through that crisis with them. With that frequent monitoring, also to see if they're tolerating the medication well. You have a decreased risk of intravenous drug abuse and intravenous drug associated diseases. You see a decrease in criminal activity, a decrease in overdose risk from using illicit substances, And since most of the heroin now is fentanyl, we're seeing more and more overdoses. So we want to decrease that overdose risk. You see improved family stability. For someone who's pregnant on methadone, you see improved pregnancy outcomes. Methadone's been around for a while, since the 60s, 70s. So it has a long track record of efficacy and safety. You also see a reduction in other drug use when someone is on methadone. And the goal of being on this medication is we want to allow the methadone maintained person to function normally, whether they're at work or at home, along with reducing relapse. So some of the cons, the restriction in time and place. Like I said, it's a commitment. You're coming into the clinic every day in order to get your medication, which is honestly very stressful to patients, because if they can't make it in, then they don't get their medication. So there's a lot that surrounds that, but it's just because it's a medication that's can be so dangerous, especially at the beginning, that we want to make sure everyone's safe. And there's a lot of stigma surrounding methadone. Some of the side effects are constipation, increased appetite or weight gain, excess sweating, drowsiness during stabilization. That's why we go low and slow. Males will see hypogonadism. And one of the things that we do see is a QT prolongation at higher doses above 120 to 150. And what that causes is torsades, which is an abnormal rhythm in the heart, and that can actually lead to death too. So what we do is we require EKGs at the dose of 150 milligrams to make sure that that won't happen. So how do we pick individuals to be on methadone? So yet again, there's that pool analogy. If they've had previous failed attempts, whether it's on Vivitrol, detox residential, or buprenorphine treatment, then methadone might be a good option for them. There is actually more available data on the long-term developmental and behavioral outcomes. Individuals have to have access to a methadone treatment center. So if they're in a rural area, they might not have access. This would not be a medication for them, but if they are more in the urban area or suburban, then you need to have access to that center. There's a lot of daily oversight, so individuals who do polysubstance abuse might be better suited for methadone because we're able to monitor them. Individuals with limited social support do well in a clinic because they have so much. When they come in, they have multiple people that can help them and support them through the recovery. And what we see in pregnancy that is positive towards methadone is there's a lower dropout rate for pregnant patients on methadone. The lower dropout rate is 18% relative to a buprenorphine, where you see a dropout rate of 33%. And that was done by the Mother study done by Jones in 2010, where it was an international, and it looked at international study that looked at multiple sites and showed a lower dropout rate. When I talk about buprenorphine, I will mention that with the Mother study, because they did compare buprenorphine and methadone, that buprenorphine, as far as neonatal abstinence syndrome went, they required less morphine. They had shorter stays in the hospital. So there was a lot of positives and less neonatal abstinence syndrome. So there was a lot of positive to buprenorphine, but the negative is the dropout rate. So if someone doesn't do well on buprenorphine, they're not taking their medication, they're continuing to use, that might be a pregnant individual. You might want to switch over to methadone. I like to talk about naloxone or Narcan or Cloxato, depending on which one you're using. So any person who's in a clinic, regardless if they're getting methadone, buprenorphine, or Vivitrol, needs to be prescribed naloxone. You can go to the website prescribetoprevent.org for more information. It gives prescribing directions, information for patients and family members, and information to the pharmacies. And anytime you prescribe an opioid, whether it's out of the ER, you get Norco because you had a kidney stone, or they're in a treatment clinic, you need to co-prescribe some type of naloxone. There's two types on the market. There's Narcan, which is 2 milligrams, and the newest one is Cloxato, which is an 8 milligram dose. So with the increase in synthetic opioids, Cloxato is what we've if someone has insurance, it's paid for by insurance completely. It's completely covered. We've been writing for Cloxato if they're able to make it to the pharmacy. And if they're not, we do dispense Narcan on site. To give you an example, one of my other physicians was working at a different clinic over in Canada, and there was an overdose across the street. And they only had Narcan on site. They didn't have Cloxato, which is the higher 8 milligram dose for the synthetic opioids. And when they went over there, they ended up having to administer 6 doses of Narcan in order to revive the individual prior to EMS arriving. So if they had 6, that was a 12 milligram dose they had to give. So using Kloxxado, you might have better results in reversing that overdose, since most heroin now tends to be the synthetic opioid fentanyl. So if you can write Kloxxado, that's what I would recommend because it is a higher dose naloxone. So what about buprenorphine naloxone combination? So buprenorphine is a partial mu agonist, so it does have less opioid activity than methadone. It's got a slow onset and long duration of action to block withdrawal symptoms. And the nice thing about buprenorphine is it can be dosed out of an office-based setting, and that was based on the Data 2000 rule, or it can be dosed out of an OTP. So the whole goal of buprenorphine is to expand access to treatment so that a primary care physician can write it as long as they get their X waiver. And most recently with the CARE Act, you can actually get your X waiver without taking the class, but you can only treat up to 30 people. And you can't go any higher until you take the class. But the goal is if you can provide it out of an office-based setting, that you can reach more people who are using. There's 2 types of buprenorphine. There's the sublingual buprenorphine, which goes under the tongue. And now there is an injectable form of buprenorphine called Sublocade. Sublocade's given once a month, and it's given into the abdomen. You start with a dose of 300 milligrams for the first 2 months and then decrease to 100 milligrams. So there are a couple different types. So with the sublingual buprenorphine, those are your Suboxone, Subutex, Zubsolv, things like that. We do not write Subutex because it does not have the naloxone in it. So we write Subutex is more highly diverted than Suboxone because it does not have naloxone. So we see no reason to write Subutex ever. The provider must have the X waiver I talked about on their DEA license to prescribe. And yet again, the goal is to provide more, provide in a primary care office as opposed to creating these specialized clinics like we have to do with methadone. So it's metabolized through the liver, hepatic metabolism. And because it's actually got fewer significant drug-drug interactions, and it's due to its low affinity for this 3A4 isoenzyme. So when it's metabolized, if they're on other medications, you have less interactions. If they're using benzodiazepines, you have to kind of monitor them extremely safe. We don't really recommend benzodiazepine with opioids because it increases the overdose risk. So if they're abusing benzodiazepine significantly, you might want to refer them to a methadone maintenance clinic. Mind you, you don't want methadone with benzodiazepines either, but because it has such a higher oversight, you're not sending them home with medication that they can overdose on with their benzodiazepine. You're seeing them every day. So you know if they're oversedated. Again, yeah, polysubstance abuse. You want daily oversight possibly of a methadone maintenance clinic if they're not doing well. There's impairment is not really clinically significant, and side effects typically are nausea, vomiting, and constipation. So how do we dose, or what's the dose of the oral buprenorphine? If the Sublocade is 300 milligrams for the first 2 months of the injectable and 100 milligrams buprenorphine dosing. So for sublingual injection, and yet again, we're using the naloxone and the buprenorphine, the max you can do, or the max you should do on one day is 8 milligrams. They are coming out with something called microdosing and macrodosing, but I'm not going to get into it because the studies are still out and they're only doing it in the ER where you go up on higher doses than that 8 milligrams. But I'm not going to discuss that. So target on day 2 is anywhere between 12 and 16 milligrams. The biggest thing with buprenorphine, and yet again, that's different than methadone. For methadone, if you used an hour ago, you can still take your methadone dose in an hour. Buprenorphine is different. You have to be in withdrawal to begin buprenorphine. If you're not in withdrawal, then you're going to precipitate a withdrawal. I mean, you're going to cause yourself to go into a withdrawal. So what happens is buprenorphine has a higher affinity, meaning it wants to bind to that receptor more than, let's say, fentanyl or heroin. It's attracted to that receptor, so it will bind to that receptor and kick the fentanyl off or kick the heroin off, and it throws that individual into withdrawal because of that. So a lot of people who come in and say they're allergic to buprenorphine probably precipitated a withdrawal, and that's really the most concerning adverse effect because people might not want to continue on buprenorphine if they precipitate that withdrawal because they get very sick. It's like Narcaning themselves. They get very ill. So really, when you look at them, the clinical opioid withdrawal score, which is how you monitor how much withdrawal they're in, you want them in moderate withdrawal. The length of time to induce depends on the opioid of abuse. So if heroin's typically you can start in 6 hours as long as they're in moderate withdrawal. Methadone's 48 to 72 hours. We're finding fentanyl to be more like 48 to 72 hours. So it depends on the opioid that they're using, how long acting they are. So buprenorphine's unique, and this is why you can write it out of a primary care office. Buprenorphine has a ceiling effect, and that's different than methadone. So opioid receptor availability decreases with increasing doses of buprenorphine. So opiate effects increase with each dose until at a moderate dose, then they level off. So even with further dose increases, you see no response. So when we're looking at this picture of the brain or via an MRI, buprenorphine at 0 milligrams. When you see that green area, that's your opioid receptor availability. Those are the spots that opioids can bind to. That's where buprenorphine can bind to, or methadone, things like that. So when you give 2 milligrams, which is the third line down, or second or third, depending on if you're counting up from the MRI, you see less green. So at 2 milligrams of buprenorphine, less green is there. So you have 27 to 47% of those opioid receptors blocked. Then at 16 milligrams, you see almost no green, a little splotches here and there. And that's where at 16 milligrams, you get 85 to 92% of the receptors blocked. And then at 32 milligrams, pretty much 94 to 98% of the receptors are blocked. So let's say someone took 48 plus milligrams, there's no receptors for it to bind to, so it's just a waste, nothing happens. So that's unique in buprenorphine with the ceiling effect. You cannot overdose on just buprenorphine alone because there's nowhere for it to bind. And that's why it's safer to write out of a primary care, or that's why it is safe to write out of a primary care office, because people really don't overdose on buprenorphine, with the exception if they're mixing something like a benzodiazepine or alcohol or some type of respiratory depressant with it. That can cause overdose and death because you're combining an opioid with a respiratory depressant. But if it's just buprenorphine, the more you take, eventually it levels off and you don't get any effect from it. So going up on those higher doses really doesn't do anything. So it's a safe medication to write. And actually, I find that the funny part is that people will write, 60 to 90 tablets of hydrocodone, which you can take more and more and overdose with, same with methadone. But people are afraid to write buprenorphine, even though it has a ceiling effect and more doesn't do anything. So it's kind of, I find that strange, but people get very nervous about writing this medication. So what does that ceiling effect mean? Increasing doses, there's limited effects. Taking more, you don't get any euphoric effects. You have a limit on that respiratory depression because of the ceiling effect. So that way it's safer to prescribe an outpatient setting than something like a full agonist, like the methadone, the oxycodone, the hydrocodone. Like it's much safer because if you were to do methadone, oxycodone, hydrocodone, taking more doses, you get more euphoria eventually to overdose. Whereas buprenorphine, you don't have that. So it's got a very favorable safety profile. So I always like to kind of mention this, and this has been going on for years now, but for the National Survey of Drug Use and Health Pain Reliever Misuse 2020, yet again, if you look at it, buprenorphine is the highest at 26.5% among the past year against any users. And it was the same last year and the year before. Buprenorphine tends to be the medication that people abuse the most. So why is that? Why would they abuse it if they don't get high, right? The reason is they're not abusing it to get high, they're abusing it for treatment. So let's say someone is on 16 milligrams or they are, and they don't need an extra couple strips and they give them to a friend and that friend takes it because they want to treat their opiate dependence. They're not taking it to get high. They're not taking it for any other reason. People misuse buprenorphine because, for example, let's say they told their family they're in recovery, but then they relapse. Well, with buprenorphine, you can take a dose or two, and then you can go to a family function without having any withdrawal symptoms. Versus if someone was using heroin or fentanyl, they might be using every 6 to 8 hours, running to the bathroom, exhibiting signs of overintoxication. You don't see that with buprenorphine. So when people, even though it's the highest abused substance, it's because people are not in treatment, so they're using their friends, or there's no access to an actual center to provide buprenorphine. So they're using their friends, their family members, things like that. So it's always run the most high as far as diversion, but it's not to get high. So does it work? There was a random controlled study in Sweden where they looked at 40 patients. All the patients had 1 year heroin addiction and they didn't meet criteria for methadone treatment. So buprenorphine, one part was in the buprenorphine 16 milligram group, the other one was in the placebo group. Both groups got intensive psychosocial services. They had CBT groups, weekly individuals, weekly supervised urine. And really what it shows the outcome 1 year later, 75% of the buprenorphine group remained in treatment, whereas 0% of the placebo group remained in treatment. So those who didn't get any dropped out within the first 60 days or so. And average dose was around 16 milligrams. And those that did remain in treatment, up 75% had negative urine drug screens for illicit substances. And in the placebo group, 4 of the 20 patients died from overdose, where there was no deaths in the buprenorphine group. So we select individuals to go on buprenorphine. They need to have access to a buprenorphine waiver physician. They have to have access to a counseling center. They have to have a moderate level of social support. It's an office-based treatment, so they don't have to go to a specialty clinic. If they have multiple medical comorbidities, it might be a good option because of the less drug-drug interactions. Like I said before, with the study with pregnant females, there was less neonatal abstinence syndrome and shorter hospital stays, and they required fewer dosage adjustments during that pregnancy. So what's the stigma surrounding methadone and buprenorphine? So people tend to think of opiate use disorder as a moral weakness or willful choice. They don't understand why people don't just taper off of it. They consider it substituting one drug for another. There's a separation really of opiate use disorder treatment typically from the rest of healthcare, and we see that a lot. And what we need to realize too is the language we use to discuss individuals who are abusing substances mirrors and perpetuates that stigma. So as far as it being a chronic illness, or, there's this misconception that there's this moral weakness or willful choice people want to continue using. And what they run into is many in the community believe that recovery depends solely on abstinence from all opiates, and that includes methadone and buprenorphine. A lot of residential services force the patients to taper off these medications in order to have treatment there, or they refuse to continue with maintenance on those medications. There are some counselors that consider taking medication a character weakness. And there's a fear of the patient of being ostracized if mentioning medication in mutual support groups. So Narcotics Anonymous believes that medications for opiate use disorder is contrary to its philosophy. So some NA chapters will exclude people taking methadone or buprenorphine from holding any type of leadership roles or attending meetings. Now there's something called MARS, which is the National Alliance of Methadone Advocates that educate on medication-assisted recovery. And I'm hoping that we're kind of turning a corner and eventually Narcotics Anonymous will be more supportive of individuals on medication. But there's been a trend that they've kind of excluded them, and they think it's, they can be ostracized if they're on those medications. So a lot of individuals will not mention that they are on those medications when they go to that support group. So does methadone work? And why not just taper off of it? So when we looked at methadone, so this is a study that was done by SEAS in 2000. It was looked at methadone maintenance treatment versus 180-day psychosocial detox. And what it showed, so the methadone maintenance group of it, which is the solid line, or which is the dotted line, I'm sorry. The solid line is the taper group. Methadone maintenance group receives psychosocial services for 2 hours a week along with their medication. The 180-day methadone detoxification group receives psychosocial services 3 hours a week, 14 education sessions, 1 hour cocaine group therapy. And what they did is they titrated them up on a dose, and then they began a dose reduction on day 120. And what you can kind of see is the solid line, the individuals who were in the taper group that began on day 120, you can kind of see that the proportion of patients, there was a huge amount of dropouts. So yet again, just like buprenorphine, people just, they drop out of treatment versus the methadone maintenance group, more people were retained in treatment. So, this increase in treatment retention is very important because we want them to stay in treatment and not go back to relapsing or using again. The same thing happened when they used buprenorphine. So they did a 14-week taper after a 6-week stabilization period, and the taper lasted 3 weeks. And what they found is that when they did the average dose was around, yet again, 16 milligrams of buprenorphine for the maintenance and the taper. So they started everyone at 16. They maintained certain percentage at the 16 milligrams, and they tapered those after stabilization of 6 weeks. They did a 3-week taper, and the taper group at the end of the study, at the end of the 14 weeks, only 11% remained in treatment, versus in the maintenance group, 66% remained in treatment. What they also found is the mean percentage of urine negatives for the opioids. So people who had negative urine drug screens, the taper group had 35% versus the maintenance group had 53% negative urine drug screens. So what we find is tapering tends to be less efficacious than ongoing maintenance on a prescription for opioid dependence. So people did better on their medication, and they were less likely to drop out of treatment. Substitution. So opiate substitution treatment is a term. It's widely used in Europe, and it can be really misleading for patients. So methadone and buprenorphine are treatments for opiate use disorder. They're not actually substitutions. So part of this is making a clear distinction between physical dependence and addiction. So individuals who are on methadone and buprenorphine and they're maintained on this medication with negative urine drug screens and no other criteria for opioid use disorder, they're physically dependent, but they're not addicted to the medication. So a lot of that goes back to a lot of people saying, well, you're on methadone, you're addicted to methadone, you're addicted to buprenorphine. They're not addicted to it. They're treating their chronic illness and they're on that medication. Now, are they physically dependent on it? Yes, but they're not addicted to it. So what I like to compare this to is if you have somebody who has diabetes and they're on insulin, right? So their body, for some reason, not producing enough. Are they addicted to their insulin, or are they physically dependent on their insulin? They're physically dependent on their insulin. They're not addicted. They have to take it to get better, and they have to take it to maintain and do well, or else their sugars are going to shoot up and they could go into a coma. So same thing with methadone and buprenorphine. If you remove those just because they're physically dependent on it, they're going to go through withdrawal and they could overdose if they relapse. So we need to make that distinction that it's not a substitution. It's just a treatment for that disorder. Just like insulin's a treatment for diabetes, blood pressure medication is the treatment for hypertension. We typically see a stigma or the stigma of separation between healthcare providers. So there's a reluctance to disclose taking medication to healthcare providers. So a lot of times if someone goes into treatment in the ER, the first question that they like to ask them is, if someone's doing really well, how are you doing on your buprenorphine or your Suboxone or your Sublocade? And the first question out of that provider's mouth is, why are you still taking it then? So that shouldn't be their question. We shouldn't be asking that. That's part of their medication. There's no reason to ask why they're still taking it if they're doing well. They should continue to do well. We don't ask someone why they're continuing to take their blood pressure medication if their blood pressure is under control. The medication is helping them. So just like the blood pressure medication is helping someone with hypertension. But when people disclose that they're on methadone or buprenorphine, you see a marked change in a provider's attitude, and patients get worried that they're not going to get a high quality of care. We see a mismanagement of pain control because individuals who are on buprenorphine and methadone, a lot of providers don't know how to provide correct pain control to individuals on this medication. And I find most healthcare providers really do have limited knowledge of medications for opioid use disorder, how they're used, what the dosing is. So that comes back to needing to educate our providers. Methadone and buprenorphine treat opioid use disorder, but it doesn't treat other substances, but not other substances. So mental health, physical conditions. So like if they're using cocaine, sedative hypnotics, cannabis, these medications aren't going to treat that. We still need to treat those areas. Same with diabetes, hypertension, asthma, bipolar disorder, mental health illness. We still need to have them on medications for all those things. We don't just have them on methadone or buprenorphine and not treat anything else. We treat everything. So other attributes, signs and symptoms of non-opiate disorders to methadone and buprenorphine. So if someone comes in complaining of flank pain, like side pain, all of a sudden they're like, well, it's probably your methadone, or it's probably your buprenorphine. Well, no, it's probably a kidney stone or a UTI. You know, we need to work them up for other things. Not everything is related to that medication, especially if they've been on it for years. There's no reason. You need to work them up for other things. And so that's kind of where they're worried they won't get that high quality care because they just state that it's this other medication causing it. The language we use is important. So the healthcare system, the public, does not routinely talk about opiate use disorders in medical care. So words I don't like. So when a urine drug screen, people say, I have a clean I'm clean today, I'm dirty, rather than that positive or negative. That's a term I don't like. They're positive or they're negative. They're not clean or dirty. So imagine if you had diabetes and you walked into your primary care provider and you said, guess what? I'm dirt. You know that you ate a couple pieces of pecan pie in the last week and it was Thanksgiving and you had stuffing and you're not supposed to have all those things because there's too many carbohydrates. A person doesn't walk into a physician's office and say, nope, when they go in to get their blood work for their hemoglobin, see, I'm dirty. I mean, imagine telling yourself that you're dirty all the time. And how would you feel if you told yourself that? So we don't do that with any of the other chronic illnesses. So referring to a urine drug screen as positive or negative is more appropriate. We talk about when someone comes off medication, we're detoxing them instead of using the words tapering off or decreasing the dosage, as though those medications are toxins in the body. We don't. We're tapering them off. We're not detoxifying them from something they're not supposed to be on if they're taking methadone or buprenorphine. Some of the therapy does not involve medication, is considered drug-free. So that's the implication that taking medications such as methadone or buprenorphine, that a person can't be in recovery, even though they are. Many treatment providers insist on total abstinence as a criteria for recovery. So we need to look at it, if we look at it as a chronic disease and we know it affects the brain, then being on this medication is actually their treatment. We don't need total abstinence. We need total abstinence from illicit substances, but not ones that are prescribed by a physician to treat their chronic illness. Access and effectiveness. This was the longest running study in Baltimore from 1995 to 2009 that showed that increased access to opiate agonist treatment was associated with a reduction in heroin overdose deaths. So the red line is heroin overdose deaths, and the other lines are either buprenorphine patients or methadone patients. So when you increase the access to methadone or buprenorphine by increasing the quantity of clinics they can access, you see a decrease in overdose deaths. So the last one is naltrexone. It's an opioid antagonist and it binds the opioid receptor and causes a complete blockade. It's a category C. Those antagonistic properties, they impact the midbrain dopamine release. So that comes back to, it impacts the ventral tegmental area and the nucleus accumbens. And when it affects those areas, it decreases the rewarding properties and decreases the usage. Naltrexone is unique. It actually can be used for both opioid dependence and alcohol dependence. The biggest or the hardest thing for an individual to go on naltrexone is that they have to be opioid free for a minimum of 7 to 10 days, if not longer, depending on the opioid. So they have to completely be through detoxification from their illicit substance, whether it's heroin or fentanyl, prior to initiation. So that can lead to 7 to 10 days. If it's heroin, it can be 5 to 7, but we just don't see heroin anymore really very often. And when I do, I'm a little surprised. Right? We always see fentanyl lately. So that's more of the 7 to 10 day hold. So if you give it before that, yet again, you're going to precipitate a withdrawal and make them very sick. Things you can do to make sure that they're going to tolerate it well is give them an oral dose of naltrexone. Naltrexone comes in 2 different forms. So you can do the oral before you give the injection. Naltrexone is unique, whereas methadone and buprenorphine you become physically dependent on it. With naltrexone, there's no physical dependence on it. So if you stop taking the injection or stop taking the oral pill, then you don't have any withdrawal symptoms from it. So you're not physically dependent. You have to be careful if someone has active hepatic disease with naltrexone. So we always do lab tests on them to make sure, liver function tests. Some side effects include nausea, headache, injection site reaction. If you're going to reinitiate opioids on someone who was on naltrexone, there's an increased risk due to loss of tolerance and possible upregulation of receptors. So what does that mean? If someone hasn't been on, let's say they've been on naltrexone for a year and they haven't used any opioids. If you discontinue the naltrexone and then you try and reestablish them on opioids, they don't have any tolerance, so they're more likely to overdose. There's that increased risk for overdose. You have to warn patients who discontinue the medication that if relapse occurs, the previous quantities they might have been using prior to getting the Vivitrol shot or taking the naltrexone pill, they can't tolerate those previous quantities. So naltrexone comes in an oral form. It's called, most people know it as Rivia. It came out in 1984. A single dose of 50 milligrams results in about 90% blockade of the mu receptors at 24 hours, but typically people don't do well on oral naltrexone because they have poor compliance. They pick and choose when they want to take the pill or when they want to use. So now there's Vivitrol, which came out. It came out and in 2004 for alcohol, 2010 for opiate dependence. It's a once a month injection to result in blood levels of 1 to 2 nanograms per milliliter. If blood levels are lower at the end of the injection, you consider oral supplementation, and compliance is better with this medication, but it still requires a highly motivated individual. This is good for individuals with no access to a methadone program or buprenorphine waiver physician. Patient has to be abstinent with patient is currently abstinent with frequent relapses or cravings, people in drug court. If they're recently incarcerated, it's good. If they recently discontinued opiate agonist therapy like methadone or bup, this might be an option. No upcoming surgical interventions. I put that up here. If they're going to have surgery in a week, you don't want to do this. But if surgery is 3 months down the line, then you should go ahead and move forward with it. And they have to have a history of compliance with treatment. So the key points are addiction is a chronic brain disease. It's no different than any of the other chronic disorders, and we need to treat it as such. We need to know that all treatments work for some patients, but no one treatment works for all patients. We know that since substance use disorder has a relatively poor prognosis, it makes sense to apply all those treatments. And treatment is most effective when both the psychosocial elements and neurobiology are considered and addressed.
Okay, going off on you. All right, thank you, Dr. Romanek. We have time for just a couple of questions. So I'm going to go through, let's see, when you talked about methadone, the weight gain that's mentioned, is that because of the methadone and because it causes hunger, or and if it does it drop off, or is this an initial problem like quitting smoking?
No, so methadone is, so all opioids cause weight gain. It's a side effect of them. It increases your appetite. And so when anytime anyone's on methadone or any opioid, whether it's Norco or oxycodone, and they're stable on it, then they will cause weight gain. It's one of the side effects of all the opioids, not just methadone.
Great, thank you. Another one is, even though I have to say it right, buprenorphine has a ceiling, doesn't taking more than prescribed, more than needed cause euphoria, just like other opioids?
No, it does not. There's a ceiling effect. So taking more doesn't do anything. So I know that my patients have trialed it and they find it to be a waste. They've wasted their time. Let's say they were buying it off the streets or money. They know just as well as I do, going up on higher doses. If it's just buprenorphine, like the buprenorphine naloxone, so I'll use the term Suboxone. So if they take 48 milligrams of Suboxone, they feel the same way as if they took 16 to 24 milligrams. There's no increasing effects because there's nowhere for it to bind, because we only have so many opioid receptor availabilities for buprenorphine. So what happens is they find it to be a waste, and everyone typically tries it for some reason and they get nothing out of it and they know it. And then they come back and say, yeah, I tried, but nothing happened. Well, yeah, it's got the ceiling effect. If there's nowhere for it to bind, you're just going to flush it out in the end. So no, you won't get euphoria taking it. The only way to get euphoria taking buprenorphine is if you don't use opiates, so you're opioid naive, and you take it. Well, it is an opioid. So it's just like if you were to take a hydrocodone and you've never taken one, you might feel euphoria. If you've never taken any opioids and you take a buprenorphine, then yes, you'll feel euphoria. But if you're physically dependent and you're using fentanyl or heroin, and then you go to buprenorphine, going up on those higher doses, you don't feel any euphoria.
Great, thanks, Dr. Romanek. All right, so we are going to just go ahead and start our wrap up because we're right at about 10 o'clock. Thank you, Dr. Romanek, for your actually third year in a row, and for all your information today, and for everybody attended the session today. We want to thank you as well too. Just to recap, today's presentation is again one of many webinars scheduled throughout the month of September. You can still register for any of the upcoming presentations at sccmh.org. And again, thank you, Dr. Romanek. Thank you everyone for joining us today. And we look forward to seeing a lot of you at our next webinar. Thanks so much. Have a good day, everyone.
Thank you.
Thank you.